Good afternoon, everyone. Welcome to the EASO Advocacy Stakeholder session. My name is Nathalie Farpo-Lambert. I'm the president of the European Association for the Study of Obesity. I'm a pediatrician, also a specialist in public health and global health policy, working at the University Hospital of Geneva in Switzerland. It's a great pleasure to be with you today to talk about policy and obesity, and especially in the context of the COVID-19 pandemic. It is extremely important to highlight the importance of policy, the policy work on in the domain of obesity, as people with obesity are at higher risk of developing severe forms of COVID-19 and also are maybe more vulnerable to increase their weight gain in the context of lockdown, reduced physical activity, food or nutritional disbalance, and stress. So it's now a great pleasure to open this advocacy stakeholder session. During 2021, we are going to run many different sessions in this field, and we hope that you will be able to join. And I will give the floor now to Jacqueline Bowman, who is the European Union policy lead for the European Association for the Study of Obesity.
Thank you so much, Natalie, and welcome to everybody. It's a real pleasure that so many of you could join already today, particularly in the run-up to Christmas. So we have a lot to get through this afternoon. And first off is introducing you to the team on the call today. So you have already heard from our president, Nathalie Farpo-Lambert, also on the call, so feel free to join in as well, Jason Halford. He's our incoming EASO president. Ewan Woodward, who many of you know already as Executive Director of EASO. Myself, Jacqueline Bowman-Bussato. I sit in Belgium at the moment, not quite Brussels. And also my colleague, Sophie Miller, who is also on the Brussels team as Policy Research and Communications Officer. Next slide. So let's take a quick look in terms of what we are going to be getting through today. Please bear in mind that we're going to give you some housekeeping tips as well along the way, so that this is a very interactive discussion. So firstly, well, we're doing the opening right now. We're then going to do a bit of a deep dive in terms of what do policymakers need in terms of evidence. Which I think is going to be quite an interesting discussion between all of us. Then moving on, we're going to hear about what we call the One Voice research project in terms of obesity and language. And then we're going to round up with a bit of building capacity within our advocacy community. So a few housekeeping elements. So firstly, please do tweet, share online with the hashtag evidence for policy. And as most of you know already, I'm hoping, you can follow us and mention us at EASO Obesity. In order to use the chat function, which is where we're going to be collecting all of the questions as we go through. And please keep asking. Click the chat and send to all panelists and attendees. That way we can see your message. And then if you want to see who else is actually on the call, and it's mounting as we go, just click participants to see who else is actually in the room. Now, we do have our wonderful tech person-ish today, actually our engagement specialist. And so when you want to actually say something that's not in the chat during the opportunities for discussion, just raise your hand to be invited to talk. Unfortunately, we can't put you on camera, but we can absolutely hear you. Next slide, please. So let's get completely into it then. So kicking off, we'd like you to answer the question. We're going to give you a link now to Slido. And if you could answer the question, how much is advocating on obesity a part of your daily work in terms of very frequently, sometimes, rarely, never? I wish we had some countdown music. But if you can keep voting, you can go to slido.com and then put in the hash B615, or, which I tend to find easier, just point your phone, your smartphone camera at the QR code and it will take you there directly. So far, everybody is okay. Everybody is doing something. I can see you're all arriving now. And don't forget, there's no right or wrong answer, because trust me, we've all been at all levels of advocating or not. Okay. I think you're going to have about, yep. I think you're basically just, we've just finished the poll. So could you actually go back one, Michael, because I couldn't see the results. Okay, so very overwhelmingly, almost 40% of you are very frequently advocating on obesity. A further almost, shall we say, 30% of you frequently. There's only 4% of you who are never, ever, ever. Well, I will say welcome very much so to the never, ever, evers, because it's a step that you're taking, which is fantastic and fun and really worthwhile. So next slide, please. Okay, so what I'm going to talk about before we get into the main discussion with Zhao, Natalie, and Ewan is really about, what are we talking about when we're thinking about advocacy or advocating on obesity? And secondly, how have we within the EASO community thus far, certainly at policy level, been addressing the challenges and how we can actually make change? Next slide, please. So I thought I'd actually start with, what do we actually mean when we say advocacy? Because what I may mean may not be what you may mean. And so I actually took the definition from the EASO Advocacy Handbook, which we'll talk a bit about later with Ewan. But the definition that we have is that advocacy is when a person or organization or body publicly supports and champions a cause or campaign with the objective of making change, some kind of change. That's what you need to retain. In our world as well, we're focusing on influencing policymakers, regulators, and other players who can bring about change. That's literally where we are sitting. Next slide, please. Now, one of the big questions which is always posed is, what do you mean policy equals public health? That's what we always hear, particularly within, I would say, the scientific community at large, and certainly sometimes as well within some institutions. Well, I have to say, this is not strictly true. Please click. So basically, when you're thinking about, oh, sorry, can you go back a bit? When you're thinking about, well, what does policy have to do with me? We've actually drawn a continuum because, you know, I really had to think about this as I was preparing for today, because I take it for granted, it's in my world. And what I take for granted is that somebody somewhere within an international, national, regional, city level institution has an idea of what their pain point is. Now, what they need to be able to do is to find a solution for that pain point. And that actually starts with research and innovation. So you all obviously would know at this stage about the likes at European level of Horizon 2020. You'll know the whole discussions around prioritization of topics, when the actual call comes out. Well, actually, there are steps before that. And firstly, it's almost like a circle. So firstly, you've got the, what are the big questions that need to be solved, also known as pain points? How do you find out what should be prioritized, and go into a bit more detail? Consultations at national and EU level. Then you start looking at what's the direction these policies may want to take, which then you end up prioritizing both in time and in scope, Horizon 2020, and you move through population level interventions, as it were. So there you start looking at trends in unmet need, framework plans, prevention. Then also along the same continuum, you could also be looking at what I call access issues. So health workforce, chronic disease treatment and long-term management, health financing, and then of course you've got all the elements which again we're going to talk a bit about today in terms of monitoring and tracking. So measurements of success and dashboards, health data, GDPR, so privacy issues. And then you say, well, how do you evaluate all of that? Actually, we've got certainly at EU level, the foresight process, which is looking at future scenarios strategically, implementation research, benchmarking, impact assessments, gap analysis, all of these things together answer the pain point, which for us is resilient health systems. Next slide, please. So all of that sounds actually quite overwhelming, and it can be. From an EASO perspective, what we had to say in the end was, what really are our pain points? Well, the biggest one that was stopping us from getting obesity really addressed along the continuum as a relapsing chronic disease, there was a lot of, or not so much because we're a year and a half into all of this, but addressing resistance to dispelling myths. And we did a bit of an analysis, getting the evidence in there, and we boiled it down to 5 core focus areas. So all of our activities and our interventions, our networking, stakeholder engagement, everything is actually based to help move these 5 priorities forward. So the first element is really a sort of root cause, if you like, approach in layman's terms. So really getting policy makers to understand exactly what we're talking about when we're talking about obesity as a chronic disease. What does that look like? They know what it looks like for cancer, for diabetes, for cardiovascular, they know. But this was actually lacking in obesity at policy level. Second element related to that is actually providing obesity with the trappings of a bona fide non-communicable / chronic disease, so that we could actually shift policymakers' perceptions and approaches. And we may say, but we know it is. We have the evidence, the science is there. Actually, we haven't been expressing it to policymakers in that way. And we'll come more onto that with the one voice exercise. Which is partly why we're here today, and we're building a very definitive advocacy community, creating advocacy capacity from within, because who better to be able to advocate on obesity than people who are either living with obesity, people who are in actually researching about obesity, or people who are healthcare practitioners. Then related to that, linking EASO scientific and research slash guidelines to policy. Again, it has to count. Everything that we do has to count. And then finally, engaging across stakeholder communities. Next slide, please. So very brief timeline, because we will be moving on. So it's to say that you have to start with something, and thinking that we could just forge ahead in the obesity in the context of the wider world, it was that's unrealistic. So within our strategy, we've actually taken a stepwise approach. So firstly, pre-2018, I would say we're very good participants in various coalitions. I'm giving you the EU example because that's where I sit, and we've been really focused on that for the last couple of years now. So Biomed Alliance was our first sortie, as it were, above and beyond the EASO community. Next click. Then last year, we actually went beyond the scientific coalition community into general health. And we've been very privileged to actually be to be the chair of the task force within the EU Health Coalition, which is now 36 different organisations across pathologies and also healthcare policy stakeholders. And we're actually chairing the health systems group, which is quite fortuitous given our policy ambitions. Next slide. This year, we actually graduated from participant to leader of group to actually hosting the secretariat for Open EU. Open is the Obesity Policy Engagement Network, and we're in the EU hub. It's a global network in 16 countries, and EASO is one of the founding partners. So we were delighted to be able to bring that to the EU level environment. There are also, I think, in Italy, Germany, Spain in Europe, and the UK. So please get in touch to find out how you can become more involved there as well. Moving on from that, that actually gave us, between all of this, quite a good way of being able to, next click, of being able to say categorically, okay, we're doing great externally, but where are the champions? Where are you all, basically? So we were able to actually start developing the tools. COVID intervened, so all online, but fantastic series advocating on obesity. And then moving forwards into 2021, we'll be building on all of that capacity building. We're very privileged to be hosting the expert secretariat for European Parliamentarian cross-party interest group on obesity and resilient health systems. Why? Because resilient health systems is our key hook. We can't advocate on obesity without being relevant. And at the moment, to put it bluntly, within the EU environment, it's COVID. I think that's everywhere. It's if you can't relate to cancer, good luck. And also having, and most importantly, under COVID recovery, and that will be for the next 3 years for sure, it will all be about resilience, so strengthening the various health systems which are there. So we are focused because we would rather know that we can step forward with allies, friends, colleagues, fellow champions of the cause that is aligned with others rather than be out on our own. We can't do this on our own. Everybody has to work together. Next slide, please. So there you have it in terms of, you know, we are really, I think, has the next slide come on yet, from your perspective? Because I'm not seeing it. Okay, I'll just continue. So, sorry, could somebody tell me if the slide has come on?
I think we've lost the slides for a second there. They're coming back up
Okay,
now, Jacqueline.
Yeah, great, thanks.
There we
Okay,
go.
so basically, I just wanted to round up with a massive lesson that we've learned as well, which is, I would say, it's about being flexible. So keeping our objectives in mind all the time. But stuff happens, and what happened for us, which actually turned out to be quite significant, is that because of COVID and all of the evidence that was suddenly appearing on, as Natalie mentioned, COVID and severity of symptoms due to differing levels of uncontrolled obesity and pre-obesity. And on the 15th of July, the ECDC, so the European Centre for Disease Prevention and Control, along with the European Commission, published their COVID preparedness plan, and for the very, very first time mentioned specifically obesity as a population of medical vulnerability due to pre-existing medical condition. That was a first. Next click. That was quickly followed as we started going through the whole legislative approval process, because Commission communication is a piece of soft legislation. We scrambled literally to get our MEPs, our members of the European Parliament, champions, to table amendments. And they did, and they got through. They got through the committee, Health Committee, in July. They got through the entire plenary in November. In between, on the 9th of September, the Commission published their foresight report. And what that meant was, for us, manna from heaven, because for the very first time, in terms of looking forwards to setting the policy agenda, using evidence to inform the policy, very clearly stated, they said, as far as healthcare resilience is concerned, or healthcare system resilience is concerned, the two chronic diseases which should be paid attention to are cancer and obesity. So in one fell swoop, we moved from lifestyle choice, banging on the door, in the course of a matter of months, we moved up to chronic disease status. And we also moved from being, who are you, to being able to command the respect of over 38 different organizations. You can see the logos on the left. 38 different organizations and 6 key MEPs who had all been involved with, in an important way, in actually the program that we're fighting for, the EU for Health program, which allows us to be classified as a chronic relapsing disease. So it's to say that it doesn't always go smoothly, but to have a plan up front in the first place and know what our objectives are, it saved us. Because I can say that, and I know that there are many of the protagonists, shall we say, on the call today, that we were literally crawling to summer. We literally, and we all sat there and huddled and said, how can we make this work as a team? And that's what we had to do. And we wouldn't have been able to do it had we not actually had our plan, our general ambition up front. And this is across different collaborating channels that we use. Okay, next slide, please. So I've said a lot. I've seen that there are a few questions already. Do I have time, Michael, or not? And I think you're on mute because I can't hear anything. Is there time to take a couple?
Yeah, we can save the questions until the just after Zhao Braider's presentation, perhaps.
Yep. Okay. So I shall move on then into our next segment. So if I can ask Zhao Braider. Oh, sorry, no, not yet. In fact, I'm going to ask you all a question because I have bared all, not quite yet, Zhao, but hello. So I have bared my soul. So I'm now going to ask you all a question via Slido again. So we face barriers that prevent our work from being implemented into health systems, whatever our work may be. Which of these most closely reflects the main barrier in your country? So for you in your day-to-day. Go to Slido, start voting. I'll read as we go. So policymakers' lack of awareness on obesity. Ooh, that was fast. It's hard to reach policymakers. Our message on obesity isn't clear to policymakers, and lack of scientific evidence to support policy. Well, that's a 0 so far. So keep voting away. That is very high. 80 and above % policymakers lack of awareness on obesity. Please get ready, Zhao, for this Q&A. Okay, and I see someone else, Laura, adding attitudes toward obesity. And yes, you will get the presentations as well. Okay, so we've got 70% on policymakers' lack of awareness on obesity. Well, let's just say that we're going to dig into that a bit more in the next section. Yeah. And that brings me on to the big question of, how do we actually identify what policymakers' needs are on the evidence? Because that ties in very much into awareness of obesity, because if you don't know what you're dealing with, how do you know what the evidence is? So how do you know to ask the right questions? It's a vicious circle. So what a real think about this, because I had some really, I would say, interesting experiences when I first arrived at EASO and was talking a lot with colleagues within the policy environment in Brussels. And I'm not going to say there were easy conversations for the very main reason that was voted in the poll just now. But if you come back to linking the evidence with needs, you then have to say to yourself, is my idea of evidence also your idea of evidence? So those of us who have to deal with data as well as qualitative evidence, self-reported, all kinds of stuff, what is actually a line between policymakers, you and other stakeholders? That's the first thing that we have to do. We have to align. And in order to do that, I would say it's not just a one-off conversation. It's not just, which I've seen in other environments, it's not just saying, I have a research paper, this is it, end of story. I've presented my facts, this is it, please implement. It may not be what they need. So, so I would say patience in terms of aligning together on what is the desired outcomes, not of the desired outcomes of the research, but in the real world. So someone mentioned attitude towards obesity. Is that something that we want to fix? In the European Union, actually, that question, which is another one of my points, the question actually has to be changed because we can't change attitudes through law directly. but we can change laws on discrimination. And we can talk about discrimination in access to healthcare. We can legislate on that, but we can't talk about, well, I'm going to give you a fine because of your attitude. We can't do that. So then you have to, yes, so I've covered the, does the evidence address the actual question? And then what is good enough? And I think that's something that we really struggle with within the scientific community, because everything has to be so perfect. Actually, no, it doesn't. It needs to give for policymakers, in my experience, which Zhao, please correct me as we go through, and Natalie, it needs to be good enough to actually start deciding, do we need a gap analysis? Is there something striking in the trend? Can we actually get going with this? That's what we actually need to be thinking about. So on that note, I'd like to bring Zhao Braider in. You can put your camera on now. He is currently head of the WHO European Office for Prevention and Control of Non-Communicable Diseases. And Zhao is Portuguese. I don't know if you're in Moscow or Greece at the moment, but you're somewhere. And has been a great friend along with colleagues of EASO for decades, all the time at WHO, as well as when you were still in your home country. And so we're going to talk with Zhao and then bring in Natalie and Ewan to actually go through really, you know, what's the reality? What do policymakers need? Yeah, so welcome, Zhao, in the first instance. Yeah, you're great. Okay, so if I kick off then, Zhao, you know, what do you make of all of this so far? What do you make? I mean, what's your experience? Am I being too theoretical, or does this ring a bell?
No, I thank you very much for the invitation. It's always, I'm always delighted to spend some time with my friends from EASO and really thinking about and discussing about opportunities and the best way to support patients and their families. So I think that's really very important. In WHO, particularly in the European region, we were by far the first ones to address the issues of obesity. I had the pleasure of participating in the first world conference, the first conference in the world focused on obesity in 2006 in Istanbul, which was actually led by the WHO Regional Office for Europe. So already really many years ago. And the charter at the time was adopted, was a very serious one. Interesting part is if you read it today, many of the things that member states declared in that charter are not yet implemented. Both from all the continuum, from prevention to long care, treatment, and all of those things. So there's really a long way to go. And I think that we need to first start with the facts. And the facts are that, hence, coming back to your evidence element, evidence is never enough, and evidence is always good enough. Depending on very much what you actually need to achieve. And I've seen the most sophisticated evidence not taking us very far, and sometimes other tangible, simple, well-communicated evidence really making a big difference. Mm-hmm. And the point here is that we're in a group of countries where half of the population is either overweight or already obese. So obesity, I'm now sitting in snowy Moscow in Russia, by the way. And it's of course beyond the borders of the European Union, but it's the biggest country in terms of territory in the world and really a huge population, 30% already with obesity. And people in the Ministry of Health already recognize that they acknowledge this is probably really very serious problem, which is going to get worse before it gets better. So I think it's a very important starting point. Now, with the advent of COVID, we realized that many of the things that were really not done in terms of preventing and tackling, managing properly non-communicable diseases are at the core of the severity of COVID and mortality. And that's a fact. I mean, we had a small impression when we start seeing the first data back in April, May, but now we have a very solid set of studies that really identify obesity as an important element together with diabetes and particularly hypertension, cardiovascular diseases, and so on. And that's really, again, unfortunately, an opportunity to remind those that have to make decisions in terms not just of the health systems. That one is very important because the response to chronic diseases is far from perfect. It's not just obesity. Obesity needs to be, and is part of it, has to be part of it. There's no other way. Many people don't acknowledge it, but it has to be there. And on top of that, we have so we're keeping track of this. So we're looking at the progress that countries are making towards SDG, right? There's one on health, 3.4.1 is mortality, premature mortality around non-communicable diseases. Most of the countries that are not going to achieve that target are actually EU countries. The Eastern European countries that are not included.
It's embarrassing.
Are, of course, they are starting from a worse position, but those in the East, for example, are moving faster. Therefore, they will reduce very significantly. So I think it's very important to understand that half of the countries are not going to achieve. And obesity is really one of the reasons why, and we actually all know that. So very few countries. You are muted.
Great. Could I press you a bit there? Because, I think that you're spot on. Certainly within the European Union, the population which is most affected, in the news right now of COVID is the adult population. And according to Eurostat figures, 59% of the EU population, adult population, has pre-obesity or obesity. 59%. Now, that's a staggering and quite frankly scary number. And what I would like to know is, from your experience and everything that's going on in WHO, do you think that part of the reason that all of this is skyrocketing is partly because WHO is monitoring? I'm not sure the EU is doing such a good job in terms of monitoring the disease progression and actually the severity levels as opposed to the prevalence levels of obesity. And it's certainly never within today, but I think everybody's making strides for sure. But in the past, it's not been measured like other chronic diseases. It's been under the lifestyle and prevention. But
well, I mean, yeah, but I would say that a very large number of countries in the European region have, and particularly those in the EU, they have systems that monitor reasonably, I mean, the prevalence of the situation, and you can actually look at different levels. If you look at childhood obesity, we have the biggest surveillance initiative in the world. We've measured more than 1 million people in 35 countries. So you can go to the US, you don't find the same. You can go to any other region of WHO globally. And it's amazing because it has made a difference. If you want to really address child obesity in adults, you should look at the way some European countries actually dealt with childhood obesity because they were successful, because they developed great systems to look at the data. They developed, let's say, advocacy at country level, because let's say, the responsibility and the capacity to change things on the ground, on the health sphere, still lies with the member states and not with the European Commission, as we all know. So it has to be countries. And you have great examples from a handful of countries that said, okay, I have a prevalence of almost 40% of kids overweight, maybe in some cases almost 10% severely obese, very serious health condition. What can I do? Can I use, taxation? Can I improve the way health systems deals with kids? Can I do this? Can I do that? And those who have made small advances, but in a comprehensive way, now you're seeing results. There's countries like,
Portugal.
Slovenia, Portugal, Italy, but more. I mean, there's more. There's several where it's sort of kind of leveling off. So there are good examples there. So I believe that the data is there also in adults. You could make a different use of that data, right?
Yes.
And look a bit more. If I recall, one of the things that really impressed some of the policymakers we discussed with, and one of the studies we launched, actually one of your EASO congresses, was on severe obesity in kids. And that was amazing because people wouldn't, severe obesity is like something really serious, and people were really impressed. The prevalence seems very low, but it's actually very, very serious. But it's kind of sometimes how you package and how you sort of wrap it in a way that conveys a simple message that then can generate some action. I think with COVID there is an opportunity, unfortunately, because it's due to this grim situation. But having the right data, that's one of the things I don't know, maybe I'm very happy to share that we have a big meeting with the specialists from several countries. We call it Meeting of the Minds. And we were discussing the issue of COVID and obesity, also from the data perspective. So we looked at big data sets which are being shared publicly. And we looked also at of course, at the prevalence and all of that and the causes, the impact, not just on obesity, but also on health, diet-related behaviors and physical activity and so on. And it was really amazing. It's a great collaboration, and there are good opportunities to use these new sources of information to really generate action. So you can build a story. It's a real story around not addressing obesity properly. And in times of COVID, it's more important than ever. Also cancer. I mean, did we explore the connection with cancer as much as we can? Of course not. I mean, cancer after tobacco, from the 50% of cancers, of which we more or less know where they are coming from, tobacco is of course number one. And then after that is probably adiposity, it's probably body fat. Do people know that actually obesity is a very important topic when it comes to cancer? Everybody's super scared of cancer, but we are not using that. And I mean, we, WHO with IARC, made that review in 2016. Maybe some of you have not even seen the report, you see?
Well,
so
I think maybe this is part of it, because I've got a couple of questions, and I'm going to bring in Natalie and you in as well, because I can see them with their cameras on. They are ready to speak. But I have a couple of questions, which I think certainly builds on what you've been saying. So again, WHO has evidence, really good evidence, which is actually the evidence in itself, clearly from what you've told us and other reading, but clearly it is answering a need and a pain point. Why is it not getting through? What do you think policymakers need to actually have that link and say, okay, this is how we're going to proceed?
It's
Is
a
that a question for Zhao again or for us? I could maybe say a word on that, Natalie.
I'm
Well,
happy to.
I think, yeah, go on, Natalie.
No.
Go on.
Oh, my experience and point of view is that sometimes politicians are not ready to talk about this topic and to address this issue, or it's not the right time in the context, the actual context, and what seems to me important is to use the data and different data. Sometimes it's maybe the data on BMI, sometimes it's on nutrition, on physical activity, but also on screen time. And now we can use COVID-19. It's a I think it's terrible. We are facing a huge pandemic, but it's also an important window of opportunity to talk about obesity. So I have now, I think, 25 years of experience in Switzerland and in policy, influencing policymakers. And I realize that I'm more and more patient now. I wait the right time. I use different type of data. I use also the media to pass the message. It's very important. And at WHO, you have done fantastic work in the past years to show the data at some important time and say, look, that's what we have. The COSI data. It's severe obesity in children, and you do you communicate, you do a press conference to really to highlight it, and maybe pass just one message, not 10. So that's what I wanted to share with you.
Yeah, exactly.
Could I just mention a couple of things as well? I think, as usual, Joao made some really fantastic and important points about those data. We do have a lot of data. Those data are available, but I think Joao, I might get the paraphrasing slightly wrong, but you mentioned that, yeah, we're maybe not telling the story of those data properly. We're not, and so this is, I think, where our advocacy training should come in. This is where working together needs to come in, because those data are available, at least those data to start the story, to start the conversation, Jacqueline, that you mentioned at the beginning. So I think what part of our challenge is to make sure that we're telling the right stories with the right data that we have available to us, to the appropriate policymakers, whether that be at national or regional or even more localized level than that. And I think that's where we need to start working together across countries, across the region, to make sure that we have those consistent messages, those stories that are appropriate for policymakers. Because I think it is very clear that there was a huge effort resulting from those data that you had in COSI. In a lot of countries around childhood obesity. So why can't we, and we have the data for adults, we have the data for pre-obesity and obesity, so why can't we have the same level of change there if we tell the story in an appropriate way?
If I may, I think that for the adult population, there are opportunities to tell a more compelling story with the data we have from countries. This is something actually we would like, probably we would be interested in working with everybody. And I see a very interesting question about the patients and the involvement with patients. For us, it's really very important that we have that part of the story as well. Early this week, we launched an NCD advisory council of our regional director, where, EASO is also having a kind of a representation, and where we're trying to engage with all the stakeholders, right? Particularly also with patients. So that story needs to be told together, because with children, it's very compelling in its nature. Severe obesity in children. Everybody's sort of scandalized, right? Telling the story about obesity in adults, you easily, you go back to the issue of diet and physical activity and the individual approach, which is really not what you want. You want a more systemic approach. You want the health system to respond, and the health system does not respond. It's not that you don't have, it's not only not having surgery available. It's much more than that. Treating obesity starts at primary healthcare level. And then all that continuum. I'm not surprised. It doesn't exist in full for diabetes. There are some very good countries dealing with it. But of course, if it's not perfect for diabetes, how would it be for obesity? So I think that one needs to accept it. So there's a long way to go. Needs to be patient, step by step, maybe sometimes 3 steps ahead, 2 steps back. But there's a story that can be told in a more, I would say, compelling fashion, particularly for adults, because I think with kids, honestly, I think we are getting there.
Yep. Okay, I can see Natalie wanting to say something. Go on.
Just to say that sometimes we have the data, sometimes not, and we have to look at what kind of question do have the policymakers, and to go and look at the data or collect new data to be able to answer the question. Sometimes it takes some time, but we tend maybe sometimes to collect too many data. So also the selection of data, the best indicators which are useful for policymakers.
Exactly. Now I'm going to bring in very briefly Jason, and then I see that Tommy Vischer wants to speak as well. So Jason, your day job is research. What is resonating with you? How does this reflect on your current rationale in terms of thinking about the research objectives that you want to get done in your own environment?
Research is a very interesting area to be in, and obviously we're often driven by theory, and theoretical perspectives sometimes don't come in from a policy perspective, which is very much around the here and now. But our worlds do collide, and Zhao and I collided about 20 years ago when I did an experiment quite by accident which had public policy relevance, and that opened a whole new world to me and really changed the way I thought about things. Now, I'm not a policy expert, and I remain a psychologist with an interest in experimentation. But what it has taught me is you can look at your science in a different way and start not only designing your experiments better from a scientific perspective, but actually start thinking about the implications of them and where they fit in a wider scheme of things. And that was important with my interaction with public health. And again, now we're working on policy-driven research around barriers to access to healthcare for people living with obesity. And obviously I was involved in the Action.io study. So that's somewhere else where the research policy interface has very important outcomes. For adults needing access and feeling they don't deserve access to treatments, that's a barrier to get them into primary care. Or as a previous example, limiting the amount of exposure of children to marketing practices associated with unhealthy foods and non-alcoholic beverages, which has been a long fight, which we have seen the dividends. They've been slow in coming, but incrementally, through the work of our policy friends at national and international level, with coordination with WHO and other partners, we see slowly the scientists working around this area, slowly collecting their evidence in a different way and starting to orientate to the policy demands of the situation as they become more aware. So it's a very fruitful partnership. And in some examples, we're at the very start of the journey. And in other examples, we've moved quite far. I mean, we never get on top of marketing because it's like a balloon. You squeeze it and another bit pops out somewhere else. So it's constant vigilance on that one. But from a scientific perspective, it's been very stimulating, and it's good as a scientist to know that your research can have a real world impact. You know, that makes you get up in the morning.
Yeah, exactly. And your research can also generate policy discussions to try and generate policy interventions. That's a whole other story. Listen, let me bring in very briefly Tommy, because I know you've been dying to say something.
Yeah, thank you very much, Jacqueline.
Would you like to say your name and your organization and your stakeholder group?
Yes,
so that we know who you are?
Yeah, sorry, Tommy Visser, the Netherlands. I'm a scientist from the Hansa University of Applied Sciences. Great to see you all. Great talks. And Joao mentioned EASO as friends. Well, that's how we see you, Joao. We are real friends, and we are doing the same job, namely fighting obesity and making the world much healthier than it is today. I raised my hand before Jason did his bit. I think I very much agree with Jason. you've been talking about data and data-driven policy and so forth and so on. I don't agree that data is important for politicians. And over the last 25 years, we've seen that data is not important at all. If it would have been important, then obesity was solved after the meeting in Istanbul that you are referred to. And what we see is not too much. Of course, we do see some examples, but well, not evidence-based examples. But it depends on what you mean by data. And where Jason, I think he tried to discuss how you really could implement all the science into effective actions. I think implementation should start from the beginning by really learning about the real issue. And there is only one group who knows everything about the real issue, and that is the patients, if you talk about management, and populations, if you talk about prevention. So my plea would be, and I know that EASO is very good at it, but I think we are unaware of the importance of it. Start all actions with talking with patients and with populations before you define a research question. Because exactly. Then, if you have a research question, then you are absolutely sure that somebody is willing to listen or wait for the answer to the research question.
Yeah.
And in our old-fashioned research models, we do very highly sophisticated research. We present our research questions. If we are ready, we present it at ECO when we get attention from the whole world, and we get applause. And well, we are waiting for the Nobel Prize. I think we should win the Nobel Prize. But afterwards, we start talking about implementation. And then policymakers say, well, but isn't it people's own fault? And there is the COVID crisis, and we see exactly the same thing. What policymakers are doing, at least in our country, is blaming the public that it is your own fault. You are infected because you don't stay at home.
Yeah.
And nobody is talking about a real policy in which it would be the logic choice to avoid infections.
Yeah, so I would like to pick you up on that slightly, because I think we've actually just come full circle. Because when we started this discussion with all of the us around this virtual table, the first main message was, first question was, are we actually going to policymakers with the correct story to grab their attention? Story that will appeal to them, resonate with them, backed up by facts. That's actually it. So you can't go one without the other. That's essentially the message that I don't want to say panelists, our conversationalists around the virtual table have come out with. Nasla, I'm going to let you come in, and then I'm going to have to close with your final thoughts on what's your advice to people advocating on obesity, because we need to get to the next section. We needed to have more time on this, but here we are. Natalie, thank you, Tommy. We're going to keep you online. Natalie?
Well, very quickly, regarding the story, I agree that we have to listen to policymakers and to understand what they know, what they think, and what they believe they should do in the context, in the actual context. And we talk a lot about health, but we have to take into account the economical context, political, economical, social, and the COVID-19 pandemic is, I think, a good example. Is the impact of the pandemic is huge, and it's going to affect many different sectors. So we have, I think, also to think about the whole system, intersectorial, and then to see. Maybe at the moment I'm working a lot on the social impact of COVID-19 in children and how it's going to affect or to influence obesity. And I know that at the moment in Geneva it resonates in in the head of politicians. And also it's a socio-economical impact. And if I come now to talk about the complication of obesity, except COVID, if I accept the association between obesity and severe forms, they're not going to listen. Yeah.
I think that's exactly it. Zhao, I'm going to give you the last word as the person who sits on both sides of this fence. What's your advice?
Thank you. 3 points as part of my advice. One is really focus on the compelling story. I think is important based on data and good data, but perhaps there is an opportunity now to harness the opportunities by the digital sphere and all that comes from there, which we are probably not doing yet. And particularly when it comes to research, implementation research is an area where the obesity field is not moving fast enough. And I would advise also to increase the share with implementation research, see how this works in the health center, see how this works in the context of health systems and all of that. It's very, very important. The impact of certain types of treatment, all of that from the patient perspective as well. So because with implementation research, you really look at patients and the final recipient. That's very important. Second point linked with that one is really, we need to focus now more on health systems because politicians, policymakers are waking up to the need finally to invest more on health systems and look at the health as an investment and not just a cost. So invest in health is invest in preventing and treating obesity. And lastly, we need to come up with solutions. We all talk about the complexity of obesity. We know that, but I mean, leave it for the scientists in the room, and because we need to take that into account. But at the end of the day, they need to have 3 choices which are implementable and they can choose from. So this mix of things that can be done and with which you can achieve results, at least in the first times of the implementation of new policies, it's very critical. So we need to reconcile the complexity with the need to come up with something which is simple. Thank you.
Yeah. Thank
Zhao. That
you.
was really
My
nice
goodness.
advice. Thank you so much.
Yeah, thank you so much, conversationalist, particularly Zhao, for saying it like it is. Natalie, for giving your experience as well from the city level coal face. Ewan, in terms of how we can actually contribute from a society environment, and Jason as well, last minute. Thank you so much for actually making the point about, you don't have to be a day-to-day professional to make a difference. You don't have to be. And from all of you as well, from making the very, very pertinent point, we cannot do this alone. The we is each and every one of us. And most importantly, because everybody has something, but most importantly, involve all of the stakeholders and especially the people and their families and networks who are actually living with obesity upfront. We'll see something worthwhile at the end of it. So I would like to draw this segment to a close. Thank you so much. And now I'm going to mostly hand over to my colleague, Sophie, but I think I've got a little bit to do here. Moving into the next section, which actually comes back really, really forcefully on a lot of the points which have been made about framing the language. If we don't have correct language and a narrative that sells, good luck. There are so many pitfalls if we don't manage that. So I'll be quick. This is a word cloud, so you can put in as many times as you want. So when policymakers talk about obesity, what are the words you do not want to hear? I think this is anonymous. Please start typing in via Slido B615. And I can say when we were doing this as a test, it was hard. It was hard to see all of this, but I think it needs to be seen. Yeah, all of these things are, you know, focusing around what we're fighting to stop within across the obesity advocacy community. And as Sophie will talk a little bit about as well, a number of these elements have come up in our research project as well. Yeah. Gosh, I feel like I've had a minute of silence. So what's coming through? Fat, weight loss, so focusing on the weight, exercise, eat less, move more. There's some there on you know, blame, fault, the word obese rather than obesity, as obesity, you know, all of these things. I think we obviously need to take a screenshot of this as well, just to remind us. Shame on you. Okay. Okay, so deep breath, because there is a way forward. It's hard to see that. I'm going to bring in my colleague Sophie, who has actually been driving within the IMI, so Innovative Medicines Initiative, research. IMI Sophia. She's going to talk us through what's been going on with the One Voice exercise and where we can possibly go from here. Sophie.
Thanks, Jacqueline. Can you hear me fine? Good. Thanks so much for having me. I'm really pleased to be able to talk to you all today on this project that I've been involved in that's been really interesting for me to do. And I've learned a lot of stuff along the way as well, and hope to share some of that with you. And great to see so many of you online, some familiar names, some new names. And I think there's some of the team on this project on the call, as well as participants that have done the exercise themselves. So really great to see you all. So as Jacqueline said, this project is an IMI project, so an Innovative Medicines Initiative project. It's quite a large project. It's 5 years, and there's 29 partners, of which EASO is one of the partners. The name of the project is SOPHIA, which stands for the Stratification of Obesity Phenotypes to Optimize Future Obesity Therapy. And myself and Jacqueline and other colleagues are involved in work package 8, which is focused around shared value. And as said, this exercise to talk about today is this One Voice exercise. And the objective here is to find consensus. Still the first slide, sorry, Michael, again. To find consensus and build capacity across stakeholder groups around the language we use to talk about obesity, particularly as a chronic relapsing disease. So we want to find this coherent approach. We want to move beyond talking about just prevention, and we want to make sure that the language of chronic disease is used to talk about obesity. So moving on then to a bit on the methodology. So it was an online questionnaire called a Delphi because of the process that it involves. And the purpose of using this technique is to achieve agreement among a wide range of experts and stakeholders on a certain topic that maybe there's not a consensus yet, and a bit of controversy and confusion around language in this case, and framing and narrative. And the purpose of using a Delphi method, it's based on the assumption that a group opinion is much more valid than just having individual opinions. So we're bringing people together and trying to gather consensus in this way. So firstly, our participants are a wide range of stakeholders. So we have payers, we have researchers, healthcare professionals, patients, industry, policymakers, and everybody in between. And also to mention that we also employ, we also have an expert panel sounding board, which is also a multi-stakeholder panel, and not just from within the obesity community, but really reaching wider than that to involve anybody, well, not just anybody, but to involve also people that can affect how obesity is viewed and treated with health systems, so not just the core community. And so our approach we have 6 kind of core blocks of framing. And so it's all about the narrative and the framing of the language we use, and it's kind of a vocabulary classification exercise. And so our 6 blocks, we have our causes of onset, complications, management, treatment of obesity, factors that exacerbate the disease, and then the big one, which is the definition of what obesity is. So moving on to the next slide, which introduces and gives an example of what round 1 was. So the Delphi exercise consists of 2 rounds of questionnaires. The first one being very open-ended answers. So our participants would have seen 6 or 7 questions, such as the ones on the screen. So do you have a definition of obesity that is currently used in your environment or your organization? What would you say the causes of obesity, factors that exacerbate obesity, and so on? And then they had space to reply. And so we had some wide range of responses. We had some trends there, and some trends and some conflicting as expected. And then using these words and answers and sentences and the responses we had from round 1, we used them to make statements that act as the round 2 statements. So this second questionnaire is more to gauge the level of agreement of our participants with the statements that came out of everybody's responses from round 1. So for example, on the screen, you can see the statement, the interaction between genetics and environmental factors is among the main cause of developing obesity, or statement number 19, an imbalance between energy intake and energy output is among the main causes of developing obesity. So for these, this is ongoing. So round 2 is currently underway. So answers are still loading. And in order for when we do our report on this, if we have 70% of people agreeing or strongly agreeing, we classify that as reaching consensus. And we're really interested to see what comes out. And we're expecting also probably not to have consensus on everything, but that's also interesting to see where we need to work forward on. And this isn't the end. This is really just the beginning of this project. We need to see how we can turn what we find into useful information, how it can be taken forward. So expect a lot more in 2021. There will be webinars, there'll be capacity building sessions, and toolkits that will be disseminated. And that's it from me, and looking forward to any comments or questions for a brief discussion after.
Great, thanks, Sophie. Questions from the floor. How does this resonate with everybody? Ewan, go ahead.
Yeah, well, I'd like to say that I think this is a very important initiative, because it would allow us to have a consistent approach, an expert agreed definition and consensus, which allows us to come with a common voice when we're talking to policymakers. I think there is still some confusion around the definition of obesity, where overweight plays a role, where different age groups play roles. So I think a consistent definition, a classification, if you like, can be helpful for us to come with one voice towards policymakers across the world. And I see that Natalie is.
Yep, Natalie, I'll bring you in as well.
Yeah, I agree. It's important to harmonize the definition across the world, and to talk about the same thing. And I realize that even among physicians, pediatricians, they still not recognize obesity as a disease. They use different definition, and they do not calculate BMI, and they They just say, oh, this child is overweight. And in fact, if you do the measure, calculate, and use the references, now all countries should use the WHO references, then physician would realize that the child has obesity. And very often when they refer me patient, when they arrive, they have severe obesity. So it's very important to use the same definition, same words.
Yeah, exactly. I mean, I would add as well that part of what we're doing as part of the classification, I completely agree with your points, because to be honest, that's where it came from. Originally, when we were charting the project, or this element of it, because this work package is on shared value. So what's in it for me, what's in it for you, and what together can we get behind in order to achieve. Are you still hearing me?
Yeah.
Yep, great. So my screen's gone.
I have a little.
Yep.
Sorry, I just forgot to say one thing. Is when we talk about asthma or cardiopathy or any other disease, there is a definition, clear definition. It's a disease.
Yes.
But a very simple example is hypertension. Even in sometimes the definition change a little bit if Americans change it or European, but still it's a disease, recognized as a disease, and we use some criteria to define it. And obesity is a chronic disease, relapsing disease. We need a clear definition.
But that's the thing, because what we sorry, you, and then I'll come back.
What I was going to say is that obesity is a major health problem globally. But at the same time, those of us who work in the field of obesity is a small community. We have a chance, because we are a small community at the moment, to take a consistent, agreed approach if we work together. And this will bring us even closer together, having a clear, consistent definition.
Yes, it does. And also, I was going to add that what brought us to this, because originally it's a comma in a number of other parts of this project, but something which is clearly strategically significant. And what brought us to it in the end was when we asked, what's your definition of obesity? There is one. WHO has a very clear definition of obesity as a disease. A lot of people didn't know it. So that rang alarm bells straight away. And then we started looking a bit deeper in terms of how do people use language? So where do they put weight? Where do they put BMI? Where do, all of these things. And you'd be amazed what we saw in the literature search that we did. It was interesting. So to actually, as Ewan says, have clarity, not just on definitions, but usage. To be frank, as advocates, it makes our lives so much easier. And when we're dealing with multicultural and most importantly, linguistic and different stakeholders, I want to know that what I understand is something, also a healthcare professional understands exactly the same thing, as does a policymaker. Everybody's on the same page. I'd like to bring in Laura, Laura Egerich. He wants to say something. Laura.
Great, thank you. I'm a dietitian. I've been working in obesity since 2008, and I really appreciate the Obesity Canada's look at what is obesity, because they look at the BMI, but then there's also the factor of, are you being provoked in your health in a negative way? And they divide it into mental health, metabolic health, your environment, mechanics. And so it's helpful I think it's helpful, especially for others, to understand obesity, that having a number on the scale isn't necessarily what is the definition in terms of your health. Because we all know people can have an obese BMI and be healthy and be very strong and all those kinds of things. So I like that Obesity Canada brings in the other negative parts of it. because I think having just a number, it doesn't encompass what obesity is. And thank you for today. It's been super nice to be here.
Great, Ewan?
Thanks, Laura. That's a great point. I wonder if Natalie might want to respond to that, but I think we work very closely with Obesity Canada, and of course their approach is something that we support. I'll hand back to Jacqueline. I think we might be wrapping up now, but
Yes.
maybe Natalie does want to say something.
Thank you very much, Laura. You made a very good point, and I totally agree with you. It's using just numbers. It's not a good definition of the disease at the moment. It's what we have, but we are with EASO, but also with Obesity Canada and other partners working on a full definition, including the risk of complication, and as well as also the impact on mental health.
Yeah, exactly. And I would add to wrap this session up as well, that we need to differentiate between a simple one-line definition and definition and scope. So because a scope will say, for instance, BMI along with other body measurements is measurement tools. It will never say, and that's the definition of obesity, because it isn't. They're measurement tools. And that's the kind of thing that we're trying to clarify, so that there's one line, remember the simple story, or clear story, so that when we do go to policymakers or whoever else, there's one top line, and what does that mean? So whatever the top line is, plus, and can be measured by, manifests as, and that's how you get your paragraph and basically elevator pitch with lots of evidence to back it up as well. But that's really the one voice exercise, is really to start putting clarity into the usage. Indeed. Natalie,
Jacqueline, just to remind people that a true definition of obesity is an excessive amount of adipose tissue, but the problem, it's difficult to measure precisely adipose tissue. This is why we need surrogate measures like BMI.
Yeah, absolutely. So and that's why it gets quite granular by the time we finish, but so that people don't keep on interchanging for a shorthand. Okay, so all of that has brought up a lot of questions along the way, a lot of discussion. Question is, how do we deal with it? How do we have and thank you, Sophie, sorry, I was moving on. And how do we deal with actually advocating on obesity, and how is EASO there to support us? I'm handing over to our Executive Director, Ewan Woodward.
Thank you very much, Jacqueline. Well, I think it's poll time. So the first thing we're going to do is a quick poll back onto your Slido. And we're asking you, which of these are you most in need of to build capacity for advocacy? So what are you as an individual or as an organization missing when you want to have the tools available to you for advocacy? Is it stakeholder mapping techniques? Is it how to make contact with stakeholders? Is it adapting messaging for stakeholder? Is it pitching your message? So please complete that, and we'll tell you a little bit more, and we'll wrap up.
And just a word, you do not have to be an EASO member to complete this question either. It's for everybody.
Yeah, absolutely. That's interesting. There's quite a need for all types of capacity building, and obviously we're needing to adapt messaging, but also undertaking some of the other techniques as well. So maybe in the interests of time, we could go to the next slide. And this is really just a wrapping up slide. I'm not going to go into a huge amount of detail here, other than to say that EASO has developed some strong programs to help build advocacy capacity within our membership and indeed beyond our membership. So we'll be undertaking a series of these advocacy stakeholder sessions. This is the first one, and it's been really a delight to see the level of engagement, the huge amount of question and chat that was happening on the sidebar, and just the general interest in this area of discussion. So we also are developing some targeted and specific advocacy training. So we have advocacy handbooks that we've developed in the last year, and we use them to undertake training sessions on advocating on obesity. So these really take people through an advocacy campaign in a step-by-step approach, building on case studies, building on real life case examples, in fact, and going through point to point to develop and implement advocacy strategies. So we have some next editions starting in Q1 of 2021, which will be based on some real advocacy challenges, in-country challenges. We'll be making an announcement about registration and the timings for that just after the break. And then we will also be undertaking policy clinics, which are really more detailed policy trainings specific for certain advocacy challenges, certain country profiles. And we are also undertaking an EASO Explain series where we'll be doing interviews and discussions with various key opinion leaders, policymakers, and members of the EASO community. So you can find out more both on our website, which is www.easo.org, and you can also make contact with us at advocacy@easo.org. I'd like to, final point is that we're here to support you. We're here to work with you. We work very closely with our dear friends at the ECPO, the European Coalition for People Living with Obesity, because they play such an important role in advocacy, and they're so important to the work that we do together. I'd like to thank them for their contributions. So I think it's very important to remember that in advocacy, we have to be focused, we have to be determined, but it's really very important to be trained and to work together. So that's my last piece. I wonder if I can hand over to Jacqueline and Natalie to give a final wrap up. But thank you so much for your attention and your contributions today.
Yeah. Okay, Natalie. Thank you.
I would like just to thank all the speakers, but also and most importantly the EASO team who prepared this session. I hope that participants have learned something and also have been inspired by this session. So I wish you all also Merry Christmas and Happy New Year despite the crisis, and take care everyone.
Yeah, thank you.
Thanks, Natalie.
Okay, and my final, just to say thank you all for being so candid and sharing your experiences and where we go from here. Thank you to a great audience, and thank you again to the entire team for getting this done so close to Christmas. So we'll be sending you all an evaluation form. Please fill it out, including, would you recommend us to other people? We thought we'd be brazen. And also, we would ask you, if you want to be kept informed, please do, of upcoming advocacy support activities. Please register that you're interested to know. We've got the policy conference coming up on the 4th of March, which is online, and the speakers list is actually shaping up very nicely. So I would say, if you haven't already, mark your calendars for the 4th. And I would say, have a fantastic, and we all know very well, deserved break to the end of this year. And looking forward to connecting with all of you in one way or another coming into next year, because we're strong together. Thank you.
Thanks, everyone. Take care. Stay safe. Safe. Keep warm in Moscow, Zhao. Thank you so much for your contribution.
Thank you very much.
I will. I'll do my best.
Bye, everyone. Thank you.
Bye, everyone. Take care.